We are going live in 5, 4, 3, 2, 1. We are live.
So hello everyone and welcome to today's webinar of learning from real life case scenarios of osteomyelitis in children. So on behalf of West Zone Association of Indian Orthopaedic Association and Pediatric Subcommittee of IOA, I would like to welcome to all our guest speaker, Dr. Taral Nagda sir from Mumbai, Dr. Sandeep Patwardhan sir from Pune, Dr. Manoj Padman sir from Delhi, and Dr. Deepak Khurana from Jaipur, and Dr. Rohan Parwani from Rajkot. So we are very happy and glad to you all could be here today to share your insights. So we're getting directly get straight on a topic. I would like to welcome Dr. Taral Nagda sir for his first topic. So please, Taral sir, you're most welcome.
Yeah. So I hope I'm heard and my slides are seen, right? Okay, I'm ready to go. Kamlesh?
Yes, sir. Yes, sir.
Okay.
Yeah.
So I'm going to present two scenarios in 10 minutes, which I have. One is a very typical case of a acute osteomyelitis in a child, and I'm going to show you actually a real case where how did I manage, how did I diagnose, and how did I treat it, And I'm also going to show you a different scenario. Nowadays, what we think is acute osteomyelitis, something else. So I'm going to show you one of those cases where it was not infective osteomyelitis, but something else. Okay, sir, Kamlesh. So, this was a case I'm talking about.
Yes,
8-year-old child, which presented with fever and inability to walk. And this child presented to a pediatrician. So the issue is, whenever there is a fever and a lower limb complaint, it should ring a bell in a pediatrician's mind that this can also be an orthopedic case. But it really doesn't happen most of the time. Most of the time, they will try to think of some other causes before they think of osteomyelitis. And this is exactly what happened to this child. On 13 January, the child had fever. By 15 January, he had pain in both limbs and difficulty in walking. And the diagnosis by the pediatrician was, probably viral myositis or something like that. And the child was treated with antibiotics and routine investigations were done. When the child actually became toxic, he was transferred to a tertiary care center, whereby with lower limb pain, inability to walk, fever and toxemia. So this is how the child looked when he was admitted. And what we did at that time, you can see in the emergency department, the few things which need to be done, though, as an orthopedic surgeon, we may be suspecting osteomyelitis. There are few checklists which we have to take care of. Check the child's fever, look at all the past investigations, look at the temperature chart over last few days, go through the investigations which have already been done. Now you can see that I have put a pulse oximeter on the child's finger, and this is done to record SpO2 and record the child's pulse. We want to know how toxic the child is. We have put an IV line here, and when we put an IV line, it's a long-standing IV line because this child will require IV access for a long time. So don't put it on the wrist. This child has a long-standing IV line which has been put, Medline has been put in this child. And when you do that, you collect blood for CBC, ESR, CRP, and also we do blood culture at that time. Don't be in hurry to inject antibiotic at this stage. I'm sure this child was already on antibiotics, but don't upgrade and start a new antibiotic till the time you obtained a sample for culture. Okay, so these are the investigations which we send this child for from the IV access which was there. The radiological investigations which I do in these cases are X-ray, which is done immediately, and also MRI on emergency basis. MRI today is a gold standard in diagnosis of musculoskeletal infection. Few years back, maybe 5 or 6 or 8, 10 years back, when we used to mention MRI, people used to say not accessible, may not be able to afford, will anesthesia be possible? But I'm sure in today's date and age, at least in India, most of the places where we practice an emergency MRI will be available. And when you do an MRI, be ready to do a contrast MRI. for most of these children. So this was the MRI which was done, and you can see this child had bilateral pain, and it showed a dual problem. It shows a septic arthritis on the right side. On the left side, there is no fluid in the joint, but you can see that there is marrow which shows bright changes on contrast. So this is acute osteomyelitis of the proximal femur on the left, and simultaneous septic arthritis on the right side. So when you have multiple infections like this, you have to beware that this could be a difficult bug. There are very high chances of having MRSA or some such organism in these cases, and you have to be ready for a longer battle in children like this. So what we did for that child is, this was late at night, but we did not post this case the next day. These are few orthopedic emergencies. It needs to be tackled as early as possible, because if you don't tackle it in time, the osteomyelitis will have pus around the shaft subperiosteally, and that would make the bone dead. So it's a sort of a race between time and saving the bone, and that's why you should treat it as early as possible once you confirmed it on investigation. So we draped and prepped both the sides. On the right side, we put in a needle in the hip joint, and that drained us pus. And because there was frank pus, we immediately went ahead and did arthrotomy on the right side. Okay. On the left side, what is done is you go to the radiologically indicated site. First, put in a K wire. On that, I will put a J needle and then try to aspirate the pus first. And then at that site, then we made a small opening. And this does not require making a window. Okay. It really doesn't. If there is a liquid pus, you don't have to make a window. What you actually do is make 2 millimeter drill holes, 2 or 3 at different levels. And then you can wash out the content through that. And then there is a literature to support a sort of a drilling rather than actually making a window and curate out the whole cavity. The whole idea is to drain the pus. The whole idea is not to treat it like a simple bone or a bone cyst and evacuate or debride the whole medullary cavity. If you don't get a liquid pus, but there is granulation tissue, in that case, I will make a rectangular window without sharp margins, and then scoop out and then replace that window back into its place. So that's how I treat. So as soon as we made the drill holes, the pus gushed out. It showed that it was under pressure. And once the surgery is done, the sample needs to be carefully transported. So, we inoculate the sample onto a blood culture bottle. So we don't put it in a test tube and send to a lab, but we inoculate into a blood culture bottle so that the yield is maximum. And you please tell your microbiologist that I have come at night and operated. So you have to have 2 samples. One sample is for smear, because it's important to know if there are pus cells. It's important to know if there are gram positive or negative bacteria, and smear is important. And the second sample, which goes into the blood culture, it actually goes for culture. And you must review this culture at 24 hours, 2 days, and 3 days, because the answer standardly from a microbiologist will be wait for 2 days for culture, but it's really not so. You must go through what is growing, at interval of 24 hours. Now, what happens to a child? You need to monitor the child because many times with osteomyelitis drainage, children suddenly have fever and toxic symptoms. There may be toxemia. You need to monitor the urine output. And just because we are orthopedic surgeon, it doesn't mean that we don't take care of the vital parameters. One thing which is very important in these children also to have a look at the symptoms of DVT, because osteomyelitis, especially in tibia, can many times be associated with deep venous thrombosis. And if those signs are present, some of those children will require additional care from an intensive pediatrician and may have to be put on blood thinners. So child has to be put on immobilization. In this case, initially we put him on traction, and then we put him in a Thomas's splint to protect, because it's important to protect as there are very high chances of pathological fracture happening. So I would protect this child and keep him non-weight bearing for almost a month. So antibiotic, it's a big question mark. Which antibiotic to give, which route, and how long? So I'm just going to stop for a while and ask Manoj and Sandeep, both of them, that in a situation where you are operating this patient, you are still not aware of which antibiotic, there is no culture available, you don't know what is the organism. What is your first antibiotic choice? Sandeep, to you first, and then to Manoj.
So, as far as literature and our hospital policy, as well as there's something called as your resident bug.
Right,
So,
right.
Staph aureus is usually the resident bug most of the
Right.
times, and ceftriaxone is my drug of choice as an empirical antibiotic.
Yeah, so initial antibiotic, even we give ceftriaxone. It depends on the setting, but if the patient is in that setting, typical setting, we would start with that. Manoj, anything
If the
different?
child is an NICO graduate, no, I would consider Klebsiella.
Right. Manoj?
Yeah, I mean, see, there is no specific antibiotic. It would depend on the age of the child, the scenario in which you're dealing with, and most usually it has to cover staph, irrespective of what the age is. Like Sandeep said, NICU will have gram-negative organisms, strep, pneumonia, Klebsiella. So you need to cover that as well. So third-generation cephalosporin would be the first thing. Some of them are partially treated. Then you need to kind of probably up the antibiotic as well. So that is how I would start off until I get the kind of gram stain and cultures back.
So don't be heroic and change what is going on. You would wait for a culture report before changing. What we also do nowadays is most of the hospitals I am attached to has a pediatric infectious disease specialist, ID specialist. And we really don't break our head as orthopedic surgeon. As such, we have limited brains and we don't want to utilize too much on which antibiotics and its side effects and how long. We generally ask them. And for those of you who don't have an access to an infectious disease specialist, it's possible to get an opinion from an ID specialist on a remote basis, as a through a teleconsultation. So it's not necessary that that specialist has to be present in your hospital, but you should have some of those specialist number on your contact list, so that in case of emergency you can call them up and ask that this is the situation and what antibiotic should I start. So some review from.
If I can interrupt for a moment here.
Please.
I think most of the people who may be listening to the webinar are not going to have a ID specialist. And for simple osteomyelitis, I don't think ID specialist is required, because sometimes they confuse the picture and it might be an overkill. In most of the instances, I have to downgrade the antibiotic and reduce the days of IV, which they want to otherwise give, and keep the child indoor for 3 weeks and 6 weeks. Which is really, there is no literature evidence, and we have found in 20 years of experience that it's not needed. So I would hesitate unless we are confused or polymicrobial or rare infection or non-resistant.
Right. So just some literature on basis of which we now do a current antibiotic practice. So we don't give 6 weeks IV to all patients. What we do is we do C-reactive proteins and use that as a guide to see how the child is responding. So you drain the osteomyelitis, you started the antibiotic, you got the culture, you started IV, patient is in the hospital. What we normally do is after 2 to 3 days, we discharge the patient on a home antibiotic program. The child goes home and takes antibiotics from a neighborhood pediatrician rather than being in the hospital. We call the child at 1 week post-surgery and also review him 2 weeks post-surgery. And if the CRP, which is done at 5 days interval, it shows a downward trend. And by 10 days, if the CRP has become, say, almost from 100, it has become, say, 8 or 10, then we know these are fast responders. And in those cases, at 2 weeks, we stop IV and give 2 more weeks of oral antibiotics. In those where CRP is still high, we have to find out why the CRP is high. In a case like this, which has multiple infections, CRP is likely to be high and will require a long-term antibiotic, maybe 3 to 4 weeks of IV, by which the CRP would fall down to baseline, and then you start on you give 2 weeks of oral antibiotics. Again, there are a lot of issues that whatever drug, especially for staphylococcus, what drug we have for IV may not be there for oral. Okay, linezolid is present for IV and oral, but it is a bacteriostatic drug. So that's why that's not preferred as an IV drug, but it would be preferred as a oral drug, as a follow-up drug. In many cases. So this is a review of literature. We say that short course antibiotic therapy is equally effective if they are fast responders and CRP comes down to baseline, as early as possible. So, this the protocol which I follow is I start on IV till the time culture report is available. We give 3rd generation cephalosporins. Once culture report is available, we'll go as per the culture report. We continue IV till CRP normalizes. We don't continue admission till the time CRP normalizes. We send the children home on home antibiotic treatment. And once we stop IV, we would give a matching oral antibiotic for 2 weeks. And these patients have to be followed up, at least for 3 to 6 months. They come for follow-up to the clinic, and every time they come, we'll do an X-ray. We'll do a check that there is no stress fracture happening, child is pain-free, there is no residual fever, and I do repeat CBC, ASR, and CRP at 6 weeks and 3 months before not following up the child any longer. I'm just quickly going to go through one more presentation, which is about a very specific entity called non-infective osteitis. Okay, so Kamlesh, I'll be very quick with this, and please let me know if I am overshooting my time. So this was a 5-year-old child with right leg pain, had nasal polyps, had pain, came with a right leg pain, fever on and off, not continuous fever. When you see this child, you don't see local warmth, diffuse swelling, there is no redness, and these are the child who is able to walk, weight bear. There is pain, but he is able to weight bear and walk. Okay, the X-ray showed periosteal reaction. So again, a differential diagnosis becomes infection versus tumor. MRI was done, which shows intramedullary sort of spread, and this looked more like an infection. This child, we were not sure what was happening. So initially a biopsy was done, which was inconclusive. So that's why we went ahead and made a window and we removed this granulation tissue. There is no pus in these patients. You get what is known as granulation tissue, which is, sort of a bluish gray or a reddish gray in color. The histopathology showed necrosis, inflammatory cells, no tumor, and the culture was negative, completely negative. The pain in this child eventually settled down. We didn't initially give antibiotic, but we consulted a rheumatologist. We realized that this child, when we did a whole body MRI, had some other patches of increased uptake. So this was chronic, recurrent, multifocal osteomyelitis or non-infective osteitis. So this is a condition. Another case I'm again showing here. 8-year-old child with came in pain in the left knee, and this time we took an X-ray, showed some sclerosis. We did an MRI, necrotic cells. Okay, and this child on whole body MRI had 2 such more lesions, and we realized that we are not dealing with an acute infection. So we did not do a surgery. We did a CT guided biopsy. Again, inflammatory cells without any pus cells, only inflammatory cells, no bacteria. And then this child was just treated with anti-inflammatory medications without any antibiotics. So, chronic non-bacterial osteitis is also an entity. Typically, it's a low-grade fever, fever which comes and goes. For a couple of days, child may be normal. Again, there may be fever. Child has bone pain, localized swelling, but the local signs are not intense as an acute osteomyelitis. So you must sort of know about this condition, because the treatment of non-infective osteitis is little different, markedly different from an infective osteitis. So, with these two, I'm going to stop my presentation, but any comments from the rest of the faculty members on the second entity, chronic multifocal osteomyelitis or non-infective osteitis? How would they diagnose and how it is treated?
I think you have to keep that entity in mind. You need to be aware of it. There are criteria. Now, some of them don't clearly fit in. I think if I recall, there are some major minor criteria.
Right.
Often you should be able to kind of, if you suspect it with a combination of clinical lab and a good musculoskeletal radiologist, you should be able to diagnose. Biopsy is, of course, you don't want to miss out, something nasty. So, but biopsy always comes inconclusive, and so therefore, that doesn't come into the first line of management. But you just need to remember the entity. That's more than anything else.
You need to be able to sniff it.
Yeah.
I want to ask just why you put that window back to when you take out that square window. Is it there chances of becoming source of infection and be sequestrated in future?
No, really not, because it acts as a graft. The infection has been taken care of, and I feel it allows it to heal early rather than having
any role of stimulant in acute cases.
So the problem is for stimulant or any antibiotic drug delivery system to work, what you really need is to know the organism. So when you do first time, you really don't know what organism. Suppose people blindly put vancomycin, but what if it's gram negative? Your drug is wasted. So I've seen a lot of people now do it as a second look. Whenever you need to have a second look, you will do it.
I use it primarily if the cavity is big enough. If there's a cavitatory lesion with pus, I will use this thing. And like I said, 90% of we go by statistics. 90% of the times acute osteomyelitis is staph. Okay, it's if you are in an immunocompromised situation, NICU setup, there is no cavitatory lesion, there's no dead space to be filled up, then obviously we'll not put it. But otherwise, I will use stimulant with vancomycin as a primary treatment also.
Okay, thank you, Taral sir, for a wonderful speech. And now we'll move on a second topic. I would like to invite Dr. Manoj Bhai to deliver his speech.
Can you let me share screen?
Yeah.
Is it come on?
No.
Are you allowing me to share screen? I'm not able to.
Yeah, already you are co-host, so I think.
Is that? No?
We don't
No.
see.
Yeah.
No.
No, we don't see. Yeah.
I have Taral's this thing on it still.
So okay, maybe you need to join back then, because my slides are still seen. Manoj.
No, sir. Your slide
First,
is not
open your presentation. You put a.
Yeah, it's open.
You go to the view and stop full screen. Then go to your presentation, open the presentation, and then come to Zoom, and then do share screen. Then it will come. Did you? Are you from a browser or you join from the Zoom app?
On a browser.
So this is the problem when you have Zoom loaded on your laptop.
It came default option came up on a browser. This thing.
No. So yeah. So you just leave the meeting and rejoin. Then it will happen.
Okay. Let me. No, it's okay. Okay. Yeah, I'll do that.
And meanwhile, Kamlesh, we can go to the next talk.
Yes. Yeah. So I would like to invite Dr. Rohan. Are you ready for that? Yes, Rohan. So you may start your talk. Then after finishing, Manoj bhai will join. Rohan, you are mute. So yes.
The host has disabled my screen sharing. I can't share my screen.
So anybody from OrthoTV? Hello.
Yeah. I have joined through the link that you sent me.
Nini.
Rishi, where are you? Rishi, Ashok, Neeraj. He has enabled it. He
Yeah,
has written
okay.
in text.
Yeah, sure. Yeah, can you see my
Yes.
screen?
Yeah. Yes, Rohan. Yeah.
Thank you. Thank you for allowing me to present my case. I'm presenting two cases on chronic osteomyelitis with sequestrum and how I treated them. So this was a 7-year-old child with a 6-month history of pain, discharge, and deformity from proximal leg. She was unable to walk due to pain and deformity, and there was a chronic draining sinus on the medial aspect of proximal femur. We can, on the X-ray, we can see the deformity. We can see the sequestrum also, and there is a pathological fracture with surrounding bone being hard and sclerotic. And the blood reports, they were almost normal. ESR was a bit raised, but CBC and CRP was normal. You can see the deformity also. So how I treated this was that I did a debridement of the upper third, middle third junction around the infection. I removed the bone that was hard, sequestrated. It was hard, not bleeding, and seemed like sequestrum to me. And the additional sequestrum also I removed, and I stabilized the whole construct with an Ilizaro external fixator. And I did an osteotomy distally. Next, I did bone transport to transport the distal fragment proximally. And I got union over here, and then the transport portion also regenerated. So this was the final X-ray after consolidation, and the child is fine and walking around quite well. The whole process, it took 6 months or so. Next case, I have a 14-year-old child who had a chronic draining sinus from the lateral border of foot. He had painful weight bearing also. I seem to have lost the X-ray, but the entire diaphyseal fragment of the metatarsal was osteomyelitic, and I removed the sequestrum and did a local debridement also. And then I replaced it with a cement tube, which was filled with which was impregnated with antibiotic, and I fixed it with a K-wire. Only the proximal distal metaphysis was left. Otherwise, entire thing came out easily as a sequestrum at surgery. And I put a cement bit there and allowed the soft tissues to heal. I left the cement I left the cement tube for 1 month, and then on the second stage I put a bone graft that was fibula and added a G bone, which is osteoconductive matrix. I left that again for 1 to I think 2 months, and then this got impregnated. This got incorporated quite well. And we can see the new bone and the fibula also got incorporated well. And I have lost it's been almost 3 to 4 months. I have lost him to follow up, but I talked on phone, and he has quite a painless gait now, and no problems and no recurrence of infection also. Thank you.
Thanks, Rohan. It was a nice case. So any questions from our faculty?
So we like to add for the first case, is there any chance if we distract this thing after doing the fibula osteotomy, there are chances it will regenerate in the form of deformity correction along with getting some added blood vessels, vascularity to heal that sclerotic part and get the union in the first go.
Yeah, I would have done that in an aseptic non-union, not in a septic non-union.
But still,
since it's an
CRP and blood markers are not that showing acute infection.
Yeah, but
because of this sequestrum.
Since there's a draining sinus, there has to be a local infection also.
No, yes, we can see a clear-cut sequestrum is there, which has to be removed. But other than this, maybe possibility just to avoid the long-term 6 months of Ilizaro in a child. I feel it's a bit difficult to keep.
So if I distract it and hold it in a valgus position, even then I will need some external fixator, and I will have to wait for 2 to 3 months at least.
So what is the LLD? Because Rohan, proximal tibial physis is also involved. So
it was not involved, sir. On subsequent follow-ups, I could see that the growth was not a problem there. You can see over here also, the growth is not. I haven't checked the LLD actually, but I think I'll have a look at that also. Physis seems normal, and these chronic osteomyelitis kids are the one who are lost to follow-up. That's how they ended up being chronic osteomyelitis in the first place. They are not too sincere about follow-up. I called both of them. They were not refusing. They were refusing to talk on phone also. Okay, everything is fine. Why do you want to come? Why do you want us to come back?
So excellent result, Rohan. Only thing one thing I would suggest is when we look at these X-rays later on, and this has also happened to some of my patients, that you don't see a mechanical axis or anatomical axis rather, which is completely straight. It goes zigzag. And also, if you see some area which I would worry about is this. There are chances that if this area is not protected, there may be some chance of a pathological fracture happening to that. And a very simple way to sort of protect it would be to pass either an elastic nail or a K-wire. Either in when you're doing lengthening, you pass it on and let it be, or at end when you remove the fixator, add an intramedullary wire to just act as a protective mechanism. That is what I do now.
So by the time we finished the treatment, the leg was so atrophied, I could, I was very comfortable giving her a PTB and allowing her to walk, because the PTB was holding it so well. I thought that it will really give security. And usually I put a nail when I'm lengthening also, but because this was an infection, I did not put a primary nail inside.
All right. Thanks.
Thanks, Rohan, for a
Thank you, sir. Thank you.
Great presentation. So, Dr. Manoj Bhai, are you ready?
Yes, I'm ready.
Yeah. Thank you, Manoj sir. Yeah.
Can you see my slide?
No, sir, we are
not yet. Not yet. So what happens when you click on share screen? Manoj, what is happening?
Let me get back to that now once again. It takes me to my options, and I'm choosing my option, and it's taking.
You can also choose screen as an option and then open your PPT. So whatever is on your screen will be shared with us. That is also an option.
Is that okay now?
Yeah. We can't still see. We can't see anything.
No?
Maybe because of Delhi smoke.
I know.
So,
I think what we can do is, Manoj, you email your presentation to me. We'll have the next presentation, and
Okay.
I'll share your slides from my laptop, and then you can speak.
Sure.
Should we do that, Kamlesh? So let's go to
Yeah,
the
yeah,
next
sure.
presentation. Meanwhile, Manoj will email his presentation to me.
Yes, sir.
Yeah.
So please, Sandeep sir. So can
Okay.
Yeah.
So can you see my screen?
Yes.
All right. Okay. So again, thank you, Kamlesh and Zone IOA and Taral for including me in this interesting webinar on infections in children. This is really an old work of mine, which again I am presenting. This was I had read this paper at Discourse meeting in 2017, or I think earlier, and we published this about reconstructing post-osteomyelitic defects with non-vascularized fibular grafts. And we know that in our country, we have a lot of delay, as Rohan just pointed out. People don't come in time. And we have a large amount of patients where there is a gap non-union due to a large segment sequestration like this. These are a few photographs of children which had come to our OPD, especially when we do camps in interiors. I think Taral and others also might have experienced that children actually walk into your clinic with bones sticking out like this. And you have to scan resect about 3 to 6 inches of bone. And they are left behind with large gaps which need reconstruction. So a post-infective gap non-union is really a complex problem because we have the following issues that we must simultaneously address. How do we control infection and what is adequate control? How are we going to maintain the soft tissue length? From where do we bring in the vascularity and osteogenesis potential? How do we give stability to that segment? Do I have the skill to do this operation? And what is going to be the cost to the patient? These are the factors which I consider when I'm going to do any kind of surgery. These are the options available to treatment. Those who are trained will prefer the fixator. Like I've always seen people who have done those fellowships will go to the fixator immediately. Those who have done microvascular training will go to the live vascular. People, we have been doing tibia profibula earlier, and the simpler method for average surgeon like me is non-vascular fibular grafts. What does literature have to say about it? The union rates with Ilizarov fixators are about 85 to 96%. But as Deepak was saying, expensive instrumentation, meticulous follow-up, a bit cumbersome to the patients, long duration, high rate of minor and major problems, expertise, and compliance. All these are definite issues. And you have to choose the method which suits to the patient and your comfort level. The free vascularized fibular graft, again, union rates are about 80 to 90%. But again, you need help from a microvascular surgeon and not many reports in post-infection situations. Most of the live fibular grafts have been described for the tumor conditions. And finding a pedicle in a scarred pediatric leg for microvascular anastomosis is really, really difficult. And there is a high chance of rethrombosis. You don't know after some time whether that live graft is a live graft or a dead graft with a high refractor rate. Tibia profibula is technically easy. It has been handed down to us by our teachers, but it does not align the mechanical axis and may cause later deformation, the Huntington or the Chacha's procedure. So an example of my own case, which I had done earlier, you can see that you have a gap non-union and the fibula is available there. So what we did was a proximal transfer, do an osteotomy of the fibula, transplant or shift it, and then you get a couple of KYs and plaster there, and you get a cross union, and then you shift the distal part, and then you get a distal union, and then the fibula hypertrophies. But the problem with this sometimes is that there is a mechanical axis malalignment and deformity, which may persist to adulthood. So this is a 6-year follow of that kid who came at adolescence with a healed osteomyelitis gap non-union, but a deformity which was significant and needed additional correction. So the post-infective gap non-union, our aim is to get the gap healed with a non-vascularized fibula graft, which I will demonstrate to you. What are the prerequisites? You must have a clean bed. So there should be no dead bone around. There should be no clinical or lab evidence of infection. So no discharging sinus, skin should be supple. The child should be functionally rehabilitated in a caliper. I put them on long calipers and make them walk for about 3 months so that the tissues revascularize. All that dirty fibrous tissue gets revascularized and becomes nice and supple. The CRP should be normal or negative and no discharge for at least 3 to 6 months. That is my criteria. A nuclear scan is of value if you want to do it to see if there is any activity anywhere in the bone which suggests infection, but it's optional. So you can use distractors for a short period of time to realign the soft tissue envelope and pull out the gap to length as if you want to. Also, it enhances vascularity. So this is a case where there was a gap non-union in the tibia and the fibula had gone up or overgrown. So we pulled down the fibula and increased the gap. The procedure is pretty simple. You have to open up the medullary canal with the help of a small drill, both the segments, proximal and distal. Then measure what is the defect and take an appropriate size fibula graft. Always oversize it. You can always trim it to size, but don't take a shorter graft. I try if there is an intact fibula on one side, I tend to take from opposite side because I don't want to disturb stability of that leg segment. And whatever periosteal tube or the muscle fascia is there, try to preserve it as much as possible. Then use a thick intramedullary rod or a K-wire, go across the ankle in case of tibia, and then cast it. So we accept shortening, but we must have contact at both ends and maintain the soft tissue integrity, and then plaster and then calipers. So this is the example of a leg which was having a gap non-union with, you can see those tapered ends, intact fibula. So after dissecting, we trim the edges, make the canal transverse, open up the canal proximal and distal. Opposite side fibula has been harvested. Then you pass a thick K-wire across the ankle in a retrograde fashion. Then thread the fibula over it and then pass that K-wire across into the proximal segment and seat it and make sure that there is a snug fit and close the soft tissue nicely. So this is how it looks. And I leave that K-wire outside over the heel, transarticular through the ankle, and bend it, and then we cast it. This is how it looked at the end of the procedure. Post-op protocol is protected weight bearing after radiological evidence of union. So, which is about 12 weeks or 16 weeks. Initially, they are in plaster, non-weight bearing. Then I protect that healing with a PVC brace or a caliper because a large segment of fibula needs to hypertrophy and unite. And all that dead bone has to be replaced by live bone. And those with limb-length discrepancy give an appropriate shoe raise. And we reviewed them at intervals of 3 weeks, 3 months, 6 months, and take X-rays. So this was the original series of 26 patients. We have many more now, where we had more girls, less boys, and in the age group between 4 to 14. And you can see the distribution of the bone involved. Most of the times it was tibia. Second common bone was femur, radius, humerus, and ulna in lesser percentage. And prior to the treatment, the infection was lasting from 3 to 14 months, average of 6 months. The surgery was performed from sequestrectomy at about 7 months. The gap was about 5 centimeters to about 6 centimeters. And average time for complete consolidation was about 9 months. And we have a follow-up of over 3 years for this paper. And an average limb-length discrepancy of about 3 centimeters. We had some problems. We had delayed union in 4 cases. 4 out of 52 interfaces, about 7%, because of the graft host diameter mismatch. I'll explain that. And that was treated with a supplemental plate fixation and bone graft. But ultimately all united. 1 case had reinfection, was treated with debridement and ring fixator with distraction. So this is a case example, a chronic osteomyelitis, sequestered completely. This is how it ended up. You can see the fibula overriding. So when we put a monolateral fixator, I transfix the fibula tibia distally and only the tibia proximally, so that we pull the fibula down. And then I resected the same side fibula here because I didn't want that proximal fibula to be a deforming force because of the growth arrest which had happened. So you can see after putting the fibula here, the fibula subcutaneously came back without the growth. So this never caused a problem later. This consolidated nicely. We had the fibula back with us, and that is how it went on to heal nicely. And later on at maturity, this girl just needed lengthening. So this is her picture, and this is how she went on. Another example of another tibia similarly treated. And as I said, sometimes you have a diameter mismatch because the KYR is really not very stable. Sometimes you can get hypertrophy of bone, but a non-Indian. And then you can just plate it without bone graft and it heals up. So that is what was done here. Another case of femur with a complete gap. Again, we used a fibula and a K-wire, and I used the neutralizing chest fixator with a Thomas splint for protection. Over a period of time, as I told you here, you have a wide femoral diameter and a narrow fibula. So there was a hypertrophic non-Indian. Proximal side healed well. And then I just put in a plate, stabilized that, and let that heal. And then we lengthened it again. So this is orthofix lengthening for this child and went on satisfactorily over a period of time. This is a radius, again a gap non-union, treated with a fibula stud with a distractor just to hold the length. And then with the distractor, we can compress it also once we have jammed the graft in. And that is how it healed and restored and regenerated. So that is at 2 years. You can see it growing beautifully with excellent function. So my observations were that it's quite a simple procedure for a really complex problem. Thorough debridement at first instance, proper timing is mandatory to prevent flare-ups. Refixation may be needed in certain instances if there is a diameter mismatch. Sufficient protection is important, long duration, and then good functional rehab. Stiffness, because of going across the joint, doesn't really cause a problem. No special instruments are needed. All of them healed. Only problem is limb length discrepancy, which can be addressed with simpler procedures. To conclude, it's a good procedure, 92% primary union rate, simple, no instrumentation or specialization needed, can be done by an average orthopod and is relatively inexpensive. This is available for reading in KVJS, May 2013. Thank you very much for having me.
Thank you, sir. It's really wonderful talk, and it is a really landmark article we have used so many times. Thank you, sir.
Thank you.
So any comment from faculty?
Sandeep, for femur, do you prefer a K-wire or you would put a plate? Is there a different?
So what happens is now very small kids, what really happens is what is the graft diameter available to you and what age child are you treating? If you have an older child, now I've had 6, 7, 8-year-old children who are older with larger diameters, then I won't use a K-wire. I'll put it as an aligning rod and add a plate at the same time. But if it's a very small kid like I showed you, then there is no choice but to use a K-wire primarily. Sometimes it is so distal fragment is so osteoporotic that the plate might loosen or cut out. So I prefer to do it at a second stage if need be. I use a spica with that or a fixator and a Thomas plate. But you are right, in older children, it would be okay to use a K-wire with a plate on top of that, a lock plate or something.
So what is your oldest patient for this type of surgery?
Oldest age?
Yes, sir.
About 14 years. The age group was 4 to 14.
Because the possibility of failure increases, I think, with the age.
No, it doesn't actually. You have a better bone stock. No? It's easier to put implants and control instability. The younger kids actually have a poorer implant hold. So the protection time is much larger. See, I feel the prerequisites are the dry. There should be no evidence of infection. Second, you must make that child walk on a caliper to allow tissues to revascularize. Don't do it too soon. And then you will realize even if there is no periosteum, the epimysium, the muscle cover, you place that graft, actually you will see bone forming around the fibula. And that consolidates faster. It's like you're Taral will remember Dr. Manu Kothari telling us, as he was our anatomy professor. He always said bone is formed in a envelope of soft tissue, embryologically. If you take out the whole bone and the soft tissue envelope is intact, new bone forms it, especially with children, right? So if there's no infection and you have good vascularity, bone is going to form. You just need to give us conduit. The fibula is just a conduit and relative stability, and bone will form. So that is how it works, I feel.
Right. And that conduit doesn't have to be vascular. It is
Yes,
a,
yes.
it is a
So
structure.
that is where the masculine technique
it
has
is
also
a-
come in. You know, people are putting cement, creating a tube which is going to vascularize or lay down bone and then just fill it with cancellous chips.
So it's a biological cage.
Yes, yes. And it's structurally giving stability and alignment. So that's why it works, I think. The fibula is quite strong enough for that.
Any experience with G-bone?
G-bone is terrible. Don't use it. Hydroxyapatite and
That was the
calcium.
first time I used it and it worked wonderfully.
No,
I
no,
don't know if I
calcium,
use it.
calcium sulfate. See what happens with G-bone, it doesn't integrate. It always remains as G-bone. Whereas calcium sulfate will integrate into the bone or form new bone and disappear over a period of time. Wherever you put G-bone, after 10 years, you take an X-ray, you will still see the crystals. And you don't know whether it has healed or it's G-bone you are seeing. I'm not a big fan of G-bone.
So
In my case, it seemed to like it became more bigger and become more dense. I don't know what happened. That was the first time.
It's a sequestrum now. G-bone is like a dead thing there.
Okay.
It's just there. Nothing happens.
Dr. Sandeep, any comment on the situation in between acute and chronic? When a child comes with a discharging sinus with parameter not that high, but involucrum is not that good, but have a good diaphyseal sequestrum. So,
yeah.
What is
So,
your take on that?
My take on that is radical-like tumor. Whenever there is infection with evolving dead bone, go ahead and take it out. Don't let. See, it's a play between immunity, which is giving healing, and the virulence. If the involucrum is not forming, that means periosteal sleeve is badly damaged.
So,
and with the discharging sinus, leaving that dead bone in is not going to create an involucrum. You need to get rid of it. If there is good involucrum forming from periphery on both the sides, and the child is quiescent, CRP is normal, the sequestrum dissolves. It will disappear over a period of time without the cloacae and discharging sinuses. That means immunity is good. You can wait and watch.
So in this second case, do you prefer to give IV antibiotic or oral antibiotic? Or
No. I prefer on radical debridement. Antibiotics are secondary to prevent secondary infections.
No, sir.
Go down, debride it. In this situation, I will put stimulant because I can show you cases where I have excised the hole. I put only stimulant in the tube and the entire bone has come back. No fibula also.
No, sir. If there is peripheral involucrum, but not that good to...
Yeah, that's what I'm saying. So excise the dead bone, wash it out nicely, put calcium sulfate granules, give a plaster. You will be surprised to see that entire thing regenerate.
Thank you, sir.
And Sandeep sir, you take the fibula, the periosteum will leave there. And,
yeah, I do a subperiosteal excision. The fibula comes back wherever I take it from.
Okay. And see, I have one case that after putting fibula, and there again there is a refracture of that grafted bone.
Yeah, so that's what I told you. See, the dead fibula has to be revascularized, and in the intermediate period, it's a weak bone. In fact, cortical bone will give stability, but it takes time to get incorporated. So when you feel it has healed, center may it is dead bone still. Yes. It has not formed new bone, so it can fracture. So keep a longer follow-up and protect them long enough. That's why I give braces.
Yes.
I don't allow them to do anything.
Yes, sir. So thank you, Sandeep sir, for it's a great talk. And Manoj bhai, are you ready for?
Yeah, I think so.
Okay. Please, sir.
Can you see my slide? Can you hear me?
Yes, we can hear you, but we can see
no slide.
No slides.
Oh, that must be the Delhi fog.
Can you
Taral has the emailed PPT.
No, no, no.
Yeah.
So no, he sent me a keynote presentation, which I
Yeah.
cannot open. So just send your
Can you
PowerPoint
see now?
presentation on email. I will open
And
that.
the key also.
Can you see this now?
No,
We
sir,
can see the fog.
It says
we
I'm
can see
screen
your laptop, but we can't see the slides.
We can see mountains and sea and some clouds.
Sir, open your PPT on the desktop only, then I think we'll be able to see it.
I have opened it up on my desktop.
Yes, we can see your desktop, sir. We can see.
Anyone from OrthoTV can help. Otherwise, Manoj, just email your presentation to me. I'll open.
But now it says I'm screening share. It's not. No, it's not working still.
We can't see. Yeah.
Oh my
So
God.
let me see if I can do it from my laptop and you can speak.
Manoj, it says we are viewing your screen, but your screen is just showing your screensaver.
It's giving me a lot of problems now. So what should I do? I come out again and send it to Taral?
Yes.
Yes.
Stop sharing. Send me the PPT and I'll share from myself.
Okay.
But share me not a keynote, but a PowerPoint presentation.
So till we will take a case of Dr. Deepak.
Yes, we can do that.
Yes, sir. Okay. Yes, Deepak, please. Deepak, you are kindly unmute yourself. Yeah.
Am I audible?
Yes, yes. Now you are audible. Yeah.
So I'll be presenting a case on a mimic of septic arthritis. So I will start directly on the case. This is a 12-year-old, otherwise healthy female child. Just give me presented with 5-6 days of fever, left-sided groin pain, and limp. And now, since a day, not able to put weight. She had a history of fall while playing. No any other joint was involved. On examination, the limb, she was keeping the limb in flexion, abduction, and external rotation attitude. Severe pain on any movement. Raised TLC, ESR, and CRP. So this gave a score of 4 in Coker's criteria. So since the patient was with some pediatrician, so they kept as a diagnosis of septic arthritis under evaluation. Hip USG was done and it was showing effusion. So they were very confident, yes, it is a septic arthritis. Blood culture was sent and she was started on antibiotic. And then I was called. On examination, it was looking like a septic arthritis and I advised them for further investigation. So they asked, we have done that USG. So USG will be more than enough to take it as a diagnosis, since they thought septic arthritis is more of a clinical diagnosis rather than a radiological diagnosis. This was my very senior pediatrician. So on X-ray, joint space was almost similar, marginally elevated capsular shadow. But since I have made my protocols to get advanced imaging each and every bone and joint infections. So what is the role of advanced imaging in these type of cases? So I got this article in JPO in 2017, in which they have seen the cases or evaluated the cases who have shown higher levels of Coker's criteria of 3 and 4, the patient presenting with hip irritability. In these cases, they have found 47.9% cases were osteomyelitis, not septic arthritis. Even in the patient with positive hip effusion on ultrasonography, and the incidence of osteomyelitis was equal to septic arthritis. So these results suggested that the combination of Coker's criteria and ultrasonography alone is not sufficient to make a diagnosis in a patient presenting with hip irritability, and consideration should be given to adding magnetic resonance imaging to their workup. So MRI was done. As we can see, there is hyperintense signal medial to the rami, which is not common in typical septic arthritis. And even if we see the joint, there is very minimal effusion, but mostly the collection is medial to the rami. In some images, yes, we can see there is obturator externus was also involved in this coronal stir images. So a diagnosis of pyomyositis involving obturator internus and externus was made. There was no clinical improvement even after higher IV antibiotics. And MRI was suggesting abscess formation and also indenting the urinary bladder. So planned for surgical drainage. So how common is this condition? What are the indications for the surgical drainage? What approach should be used to drain it? Whether it should be a percutaneous CD guided, USG guided, or an open surgery. So there are lots of articles on the reported obturator or periarticular abscesses. Other many approaches. So hip pain in children often possesses a diagnostic dilemma. Pyomyositis involving muscle around the hip can present with similar feature as septic arthritis and are difficult to diagnose because of their rarity and indolent presentation. Primary myositis is rare. It is subacute. Deep bacterial infection of skeletal muscle not associated with any contiguous infection of the skin, bone, and soft tissue. Etiology remains unclear, generally associated with a trauma to the affected muscle followed by transient bacteremia. Most common etiological organism is Staph aureus. In tropical countries, it's more common as compared to other. So it has different stages. Most common muscles involved are iliopsoas and obturator muscle. So what are the indication of surgical management in these cases? So MRI confirmed abscess failing to respond to antibiotics, and MRI confirmed abscess causing occlusion of an organ through a mass effect, like indenting the bladder or rectum. So using these criteria, 70% of patients, these type of patient required surgical drainage. So now comes what are the surgical options we have. So because of their anatomical challenge of the location of especially obturator internus and externus muscle, so for these muscles to be drained, ilioinguinal and phenensteel approaches were the typical approach which was previously used, or nowadays many pelvic surgeons they may use because of their extensive dissection, extensive that area, and the risk of neurovascular injury, corona mortis. There is a minimally invasive medial approach to drain these obturator musculature in children, which is known as Vanderbilt's medial approach. Since we are very aware of this anatomy because of our doing triple osteotomies, so we know that that obturator neurovascular bundle is on the superior lateral corner of the obturator foramen, and which is surrounded by the obturator membrane, and in front of it there is obturator externus, and behind there is obturator internus. So we are very sure that abscess is around these two muscle blocks. So in those cases, this medial approach can be used. So in this approach, they expose the adductor longus, they retract it anteriorly, and after retraction, we get adductor brevis. On the anterior border of adductor brevis, we can see an entire branch of obturator nerve is running, and along that obturator nerve, we pass our clamp into the obturator externus, then into the membrane, and then into the internus. So it ultimately leads to a passage through which the pus can be drained very easily. So I will explain this thing through my case. The patient is placed supine with affected limb flexed, abducted, and external rotated. 3 to 4 centimeter I prefer longitudinal incision along the adductor tendon. The adductor longus with its sheath was open. It was retracted anteriorly. And then obturator, that adductor brevis is exposed on the entire surface. You can see the entire branch of obturator nerve. And along that nerve, the clamp is passed and then into the obturator musculature to drain the abscess. The whole thing is guided through fluoroscopy so that we are not passing that clamp superolaterally, because we can damage the neurovascular structure there. So both obturator oblique view and inlet view can be used. So this is a video of me showing this thing. After exposure, see the right angle has holding that adductor longus tendon, and along with the nerve, I'm passing my clamp. And as soon as I touch, because of the inflammation, that obturator muscle is so fragile, just as you touch it, it drains the whole abscess. And after they draining it, use the pediatric suction cannulas to lavage the whole thing, and closure was done under negative suction drain. So pus was sent for gram staining, AFB and CBNAT, started on antibiotic for both gram positive and negative. Culture shown MRSA sensitive to vancomycin and linezolid. So my pediatrician, they tend to prefer use vancomycin for first 4 days because of its bactericidal nature, followed by linezolid, which is bacteriostatic, for a total of 6 weeks. And ESR CRP were monitored. So this was 4th post-op day after drain removal. He was very comfortable walking. And this was 10-month post-op follow-up with no restriction of any range. Similar thing can present with a septic arthritis along with it. in this case, this is my another case in which you can see there is a septic arthritis along with this obturator abscess, which is connected like a horseshoe shaped connection through lesser sciatic knots. But in these type of scenarios, we are never sure whether the septic arthritis is primary or whether this obturator abscess is primary. So I generally prefer to deal it with dual approach, by anterior approach for hip arthrotomy and the medial approach for the obturator. So it's better to use dual approach. Dr. Mollin also has published a case series on these and showing if that obturator abscess is not drained properly, or if only the septic arthritis thing has been tackled, these patients have a long-term follow-up with chondrolysis and protrusio. So just to avoid those things, it's very important. So take-home message from my side is be aware of mimics of septic arthritis. They are rare, but there. Always get an MRI to diagnose and plan an acute bone and joint infection. Always consider osteomyelitis in association with septic arthritis in children, and use the approach which is best in your hands. Thank you.
So thanks, Deepak. It's a great talk. And yeah, any comments from faculty?
Nice, very nice case, Deepak. It's important for everybody to realize that pseudoparalysis with painful hip does not always mean septic arthritis. Intrapelvic abscesses, iliac abscesses, osteomyelitis of the pubis, and obturator abscesses are important things which one must consider. And you did a very good job of demonstrating that. Thanks.
Thank you, sir.
Yes, Manoj sir.
Can you see now?
We can see your desktop.
Oh, Taral, I've sent it to you. I hope you can open it, because mine says that everybody can see the screen. So I'm not sure how is Taral around? So I don't know why it's coming up as it says that.
I can share. Yeah, I have downloaded.
Okay.
Yeah.
I'll stop my end. Yeah, we are. I mean, just
yes. Now we are in business.
We're in business. Yeah. So it took so much time for the fog to clear. That's the problem here in Delhi. Yeah. So anyway, all the best talks are finished. So I'm just winding up now. I think I'm the last person, right? So anyway, so my remit is to talk on the diagnosis and management of septic arthritis in neonate. And I'm going to focus here on the hip, which is the most challenging, because the other joints are more superficial and easily kind of identifiable, and one is not likely to miss it. So that's what I'm going to talk about. I thank the West Zone IOA who've invited me to talk on this. So I actually have I have talk in slightly reverse order, in the sense the first two slides are actually the summary slides for me. One has to remember that this is septic arthritis and osteomyelitis is a manifestation of a systemic infective process. So in this day and age, even if you do not have an infectious disease specialist, make sure that you have a pediatrician or a neonatologist involved in the care, because very often the bone and joint infection may not be the only focus of infection. They may have other systemic manifestations, and you may be out of your depth in handling them. You have to remember that you need to be aware of the local bacteriological profile, the resident bug, as Sandeep called it, which is based on the age of the patient, the common organisms in your locality, the sensitivity patterns, seasonal variations, and comorbidities. That would determine what antibiotic you start on. There is no one orthobiotic that you can, it depends on what is common in your locality. By far, Staphylococcus aureus is the commonest. You need to have some idea about if it is community acquired or hospital acquired. They have different kind of connotations. Methicillin sensitive is still available, occurs. The rarer bugs like Kingella kingale, we are isolating. They are fastidious organisms. They are not easy to kind of pick up, but one needs to remember that. Fortunately, they have a less toxic clinical profile. Clinical diagnostic algorithms have been touched upon. Deepak talked about its limitations, but it's focused on history, examination, and investigations. It's blood investigations. It's a useful starting point. But in this day and age, you need additional imaging. So ultrasound by itself may not be enough because that's operator dependent. MRI is important to diagnose concomitant osteomyelitis, intrapelvic collections, pyomyositis. Yeah, the next slide. So once you've got these things out of the way, early diagnosis followed by urgent management in septic arthritis, remember, is the cornerstone. The old adage about the sun should not set on a septic arthritis still holds true. Whether you choose to do arthrotomy, joint lavage, and antibiotics, or some people are proficient in arthroscopic lavage, prefer to do it that way. I'm not convinced yet of its benefits. Abbreviated antibiotic regimens are the current kind of accepted regimens. The 6-week cookbook is historical. Most pediatricians still subscribe to that because that's what is given in their pediatric book. But there's plenty of evidence about abbreviated antibiotic regimens wherein you can transition from IV to oral as soon as the CRP shows a downward trend. And the decision to kind of make the transition is based on CRP and not imaging. You have to bear in mind systemic manifestations. I've seen all of these complications in osteomyelitis, collections elsewhere. So you're doing well with the hip and suddenly you find the child has got an empyema. DVT can occur and that can cause its own problems. Some of them need multiple surgical interventions and prolonged hospital stay. Compartment syndrome can occur with tibial osteomyelitis with subperiosteal collections. You have to remember next, Taral. The role of joint aspiration is a little controversial in terms of what is its role, where do you do it, how do you do it. A lot of times you need anesthesia. So I'm not, again, in my practice, I don't use it because you need image guidance. What is its role in therapeutics and things like that. Some people do repeated aspirations as a form of this thing. Again, there is not enough evidence to, so I hardly use joint aspiration. If I believe that clinically there is septic arthritis, I'd rather prefer to drain it rather than confirm it by joint aspiration. Follow-up is important because sequelae, a septic arthritis patient can be with you for the rest of the childhood. So you need to remember that sequelae. Next slide, please. So there are a few excellent reviews which have come up in the last 4 or 5 years. Good point to start off with. There is the multi-author book, which is come out this year from Springer. Quite a few of us have contributed to it. It's on pediatric musculoskeletal infections, which covers everything. Yeah. Next slide. So what is different in a neonate? If you start off as that as a basic premise for managing septic arthritis at any age, what's different in a neonate? The clinical settings and presentations are different. The risk factors for a neonatal hip sepsis is different. There is challenges in diagnosis because the clinical prediction algorithm are not fully applicable. They're not applicable even partially treated and incompletely treated grown-up children, but neonates more so. There's often delay in diagnosis and management because more important things are being taken care of. The bacteriology is different. NICU setting, you see Klebsiella and gram-negative organisms a lot more. The clinical course is different. And because the infection happens at a much younger age, the prognosis is usually grave if there's a delay, and the risk of sequelae are greater. So what is a clinical context that you often encounter? It's an NICU child, it's an NICU baby, often premature. Low birth weight is a known risk factor for sepsis. Usually there is a concomitant focus of infection. Usually it's a lung. There is either apnea or respiratory distress. Anemia has been predicted as an independent risk factor. More often these babies have invasive monitoring, which are a source of infection, central lines, or is it a mechanical ventilation or umbilical artery catheterization. All of these are potential focus of infection for the bacteria to get into the joint. So that's a clinical context that you see for neonatal hip sepsis often. And how do they present? The signs and symptoms are much more muted. The signs of systemic sepsis are usually lethargy, poor cry, poor feed, inadequate weight gain. That's why having a neonatologist on board while you're treating this would help. The neonate often does not have a mature immune response, so there is no fever or no toxicity. And for the same reason, conventional markers, you may not find a raised CRP or an ESR or a raised count. In severe sepsis, you can actually have neutropenia, actually. We are not familiar with using procalcitonin, which is used by neonatologists for a systemic sepsis. They usually have antibiotics ongoing, which again kind of confuses and muddies the water. And often because there are other more important pressing things which are being taken care of, the orthopedic surgical involvement is much more delayed. You're called in at a much later stage. And so very often you're dealing with delayed presentation in an unclear situation. As I mentioned, bacteriology is different in the neonates. Staphylococcus aureus still remains the dominant one, but you need to be aware of group B strep and Klebsiella as potential source of infection. Nosocomial infections for protracted NICU stay, and I have seen cases of fungal infections as well. So the traditional Kocher's criteria, that's what it is, that does not appear in a neonate for the following reasons. As I mentioned, it's not validated in neonates. It was used originally to distinguish between transient synovitis and septic arthritis. That does not apply in a neonate. The immature response is not mature enough to kind of mount inflammatory response. And there's ongoing antibiotics, which usually kind of confuses the picture. So the diagnostic algorithm is not relevant. And as I mentioned, these are all these four cases are septic arthritis of the hip, and 3 out of the 4, apart from the pseudoarthrosis, were never diagnosed as septic arthritis. They just had prolonged NICU stay and history of sepsis, but they never knew, the parents never knew that the child had hip septic arthritis. So that's how, and you see the disastrous sequelae. Apart from the pseudoarthrosis, who the baby had drainage at that time, the other 3 did not even know that there was a history of septic arthritis. Next slide, please. So if I rush through a few clinical scenarios just to kind of expose you to what are the possible challenges that we're facing. So the first case, and it's very common, all of us would kind of encounter. This presented to me at 4 months. As a late preterm, there was a history of NICU stay for about 10 days for breathing difficulty. When the baby was handed back to the parents, that's the usual. You have to ask that history probingly. There was reduced movement of the left lower limb, and there was crying on attempted leg movement. Painful leg movements, that's an indicator of ongoing infection, because the only other reason is trauma. Evaluated elsewhere at that time, by that time, the systemic sepsis manifestations had settled down, and they diagnosed a dislocation. And because at that time there was no signs of sepsis, the pediatrician and the local orthopedic surgeon thought it could be DDH, it could be a neurological problem, because they did diagnose monoparesis at that time. And this is how the child presented. The left hip is what we are looking at. I hope the video plays. And often we see this scenario wherein the sepsis is burnt out, and for a variety of reasons. And unless you ask the specific history of when the child was handed back to them, to the mother, and that's when you kind of, yeah, that's the one where the video should play, hopefully. Yeah, okay, it's in the background, so it's probably not playing. Yeah, let's move on to the, okay, it's playing. Yeah, so you can clearly see, this is what you see, that the right leg, the baby is just kicking around, and the left, this is 4 months down the line. The sepsis already happened about 1 month. Yeah, so clear pseudo paralysis of the left leg. This is a more acute scenario. There's another video here. Again, you can see that the left leg is reduced movement. Sometimes this is actually in the NICU setting. There's actual active sepsis. So you can see that the baby is trying to kick out on the right side. The baby is crying because there is pain. There is no movement at all on the left leg, which is kept flexed, abducted, and externally rotated. So I'll come back to what we did for that first child. So here is another scenario wherein it's a 3-week-old baby, late preterm, respiratory distress, intubated and ventilated. There's Klebsiella sepsis, has been on IV antibiotics since birth. And at day 20, the pediatrician felt that the systemic sepsis manifestations were settling down. They noticed swelling in the right groin and thigh. They did an ultrasound which showed a collection. But at presentation, if you go with the Kocher's criteria, child is afebrile, the white cell count is normal, the CRP is still raised. So pretty much all the systemic manifestations have settled down. So if you're going to use Kocher's criteria here to intervene, you would think that, oh, the child is getting better, apart from the local signs. But that's what the X-ray looks like. And you can see that there is clearly lateralized hip. And this, in my opinion, is a subluxed hip. This is not DDH because it's moved laterally rather than superolaterally. You get an ultrasound, which is easy to obtain. You can see the top right image is the left hip, and you can see on the bottom left, the right hip, the synovial hypertrophy. It's not actually pus, the synovial, thickened synovial tissue actually pushing out the hip. And when you do a little bit of dynamic stress, you can see it sliding out. So this is instability, and this has to be tackled. It is not so much treat the systemic signs, but the local problems, which are usually seen in partially treated cases. There is sublux joint. So what are you going to do? So systemically, the baby is fine. Are you going to just continue with the antibiotics? Are you going to kind of, yeah, that's fine. Yeah. Are you going to aspirate it because this is partially treated? You're not going to get anything because it will be thickened tissue, thickened pus. Are you going to do an arthrotomy because diagnosis is established here? There is clear sepsis. And how are you going to treat the instability? And in my opinion, this should be treated because the instability is going to create a problem later. So we did an arthrotomy and washout, not so much to establish a diagnosis. I confirmed that it's Klebsiella again. The instability has to be treated. The child went on to a Pavlik harness. It was a brief period of hospital stay because it was sensitive only to aminoglycosides, which could be given only on intravenous. CRP was normal at discharge. And you could see over a period of about 3 weeks, you could see that the hip has stabilized. From the top images to the bottom images, you can see that the hip is stabilized. How do you prognosticate? Can you tell the family that everything is fine? You need to follow up. At 3 months, you can see, capital epiphysis starting to appear, but you can clearly see the difference of the proximal femur there. So that's about 1 year of age. So clearly not a normal looking hip, but at least the capital epiphysis is there. It's lateralized. There is evidence of proximal femoral growth disturbance, possible AVN as well, but we do not know where it's going to end up. But this is a better situation to have a than have a dislocated hip. But nature wonderfully takes care. As you can see, that's at 2 years of age. And that's at 6 years of age, the same hip. So just relocating the hip and addressing the stability gives it a better environment. So coming back to the first case here, yeah. And here again, you can see that the X-ray, it is lateralized. Taral, if you could just go back to the X-ray again. Thanks. So that's important that the hip is lateralized here. And so that is a sign of instability, and you need to kind of center it. It's not so much to treat the septic arthritis as such, it's the early sequelae. Yeah. Next slide. So again, a simple arthrotomy and washout. There's no pus, it's thickened capsule, unhealthy granulation tissue. We couldn't get any growth at all. So we just put on empirical antibiotic just to cover that perioperative period. But spike of an older child, so therefore spike up for 6 weeks. Intra-op findings, you could see cartilage erosion. So this may also have some problems. But at least the hip is located. Yeah. So moving on to my last case here, there's a 4-month-old baby. Again, had a 3-term baby, one of twins, was in ICU for a prolonged period, was treated on antibiotics for sepsis, settled everything well as per the pediatrician, thriving well until a recent history of irritability in the right hip. And you can see again, the right hip is lateralized here. So subtle markers here. So, and combined with the clinical examination, wherein you can see that there is reduced spontaneous movement and pain on passive movement, rest of the limb normal. So these are cases where advanced imaging would help as well, because this is a child who is doing well. And we did an MRI which showed only a moderate effusion. But if you go back to the X-ray once more, yeah. So the MRI images are not there, but MRI signals are normal in the proximal femur and in the acetabulum, but the hip is clearly lateralized and there's a moderate effusion. But no systemic signs of sepsis at all. Arthrotomy and washout, no pyogenic organisms, but grew Candida albicans. So we started on empirical antibiotics, was discharged on oral antifungals. And by the time the baby was discharged, you could see the CRP was getting normal from 34 at presentation to 14. And that's as the child is followed up. You can see that the hip is growing well. So Candida albicans, again, prolonged NICU stay, they are immunosuppressed. You can have systemic fungal infection. So I've got a few cases of fungal septic arthritis. So if I can conclude, septic arthritis in the neonate is a clinical emergency, like at any age. But in neonate, the decision-making has to be on clinical grounds, and you cannot delay drainage and antibiotics, because sometimes getting an MRI, which would require a sedation anesthesia, may delay treatment. Bear in mind, it's better to get a pediatrician or a neonatologist involved, because shared care is important. It doesn't have to be an ID specialist, but shared care in this day and age, I think, is better for a variety of reasons, not least medical legal implications as well. Abbreviated antibiotic regimens are the order of the day. Watch the joint, even if they are presenting late, burnt out sepsis, even before they develop sequelae, partially treated sepsis, or even undiagnosed. Watch the joint, look at the joint. If it's lateralized, if there is any sign of instability, treat it. Relocate it so that you have a better prognosis. Thank you.
Thank you very much, sir. So, any comment from faculty?
So the Manoj showed very well that acute septic arthritis, of course, needs to be drained. But when you have delayed presentation, and if the hip is subluxated, those are also the cases which we need to be opened up, and you may need to relocate the hip, by close or open means.
And Manoj sir, when you do arthrotomy, particularly in hip cases, so you do directly Paulic harness or you give us hip spica for immobilization?
So it depends on the age. That's the simple answer. They are not that unstable like a DDH hip. So they need protection. So they stabilize very quickly. So if it is obviously baby under 6 weeks, I would put a short period of Paulic harness. It's easy to kind of follow up. Anything older than that, I would keep a spica.
Spica. Okay. Thank you very much, sir. And I think one case not be there for. Okay, fine. So I think mostly we will end the session. Thank you very much, and whole faculty. They have spending their time, and this is a very special Sunday evening. So on behalf of IOA and behalf of West Zone, I'm very thankful to all of you. So thank you, Sandeep sir. Thank you, Manoj bhai. Thank you, Taral sir, Deepak sir, and Rohan. Thank you very much.
Good night. Good night.
Okay. Good night, sir.
Bye.
So,
Bye. Thanks, Kamlesh. Thanks, Deepak.
Okay. Bye.
Thank you.
Okay. Bye.
From OrthoTV, we can stop recording at the live transmission.
Yeah. Thank you, Taral sir, for mentoring as always.
Is it stopped recording?
No, it's still.
Chalo. Still showing.
Rishu, can you stop recording?
I think all of us can exit.
Yes. Yeah.
Leave the meeting and.
All right. Bye-bye.
Okay, sir. Thank you. Thank you, sir.